Welcome to the Practicing Clinicians Exchange podcast. This podcast series was developed from a live PCE conference focused on gastrointestinal and genitourinary cancers, including gastric cancer, colorectal cancer, hepatocellular carcinoma, bladder cancer, and prostate cancer. In each episode, you will hear the latest evidence and expert recommendations for the care of patients with a specified malignancy. In this podcast series, each of these topics will be discussed in 2 podcast episodes covering didactic presentation of the available evidence, relevant case discussions to illustrate clinical implementation strategies, and the audience Q&A session. Be sure to listen to the 2 podcast episodes for each topic in sequential order, as they may include examination of continuing case studies with patients progressing through different stages of their care. To claim your credit, please visit pce.is/GIGU.
The challenge of treatment-refractory metastatic colorectal cancer lies within getting patients specific treatment for their specific biology of their disease. We do know that systemic therapy in metastatic colorectal cancer has been shown to increase median survival in patients who did not respond to first-line treatment, especially with targeted agents when combined with chemotherapy. We also know that further systemic therapy improves median survival with increased lines of therapy. That being said, patients with metastatic colorectal cancer do not always receive later lines of chemotherapy. It turns out about 75% of patients go on to receive second-line therapy, but this drops to just over 60% receiving third line and around 50% of patients receiving fourth line therapy. The preferred subsequent therapy for these patients is really based on their molecular profile. So patients are all RAS and BRAF wild type, and they have not previously received an EGFR inhibitor, then they are candidates for chemotherapy combined with an EGFR inhibitor, such as panitumumab or cetuximab. If patients have a BRAF mutation, then they are eligible for combination therapy with either encorafenib and cetuximab or encorafenib with panitumumab. For patients who have not previously received immunotherapy, they would be eligible to receive either pembrolizumab or dostarlimab alone, or a combination of nivolumab plus ipilimumab or nivolumab alone. For patients who have HER2 overexpression, there have been studies showing that combination dual HER2 therapy can help improve response rates. This typically consists of trastuzumab plus pertuzumab or trastuzumab plus lapatinib, and also now trastuzumab deruxtecan has been shown to have some activity. And as mentioned previously, for those patients with NTRK fusions, they may be candidates for entrectinib or larotrectinib. Now, for the patients with BRAF mutations, we mentioned combination treatment with a BRAF inhibitor and an EGFR inhibitor. Now, this is based on the results of the BEACON colorectal cancer study, which was a phase 3 study, which randomized patients with either 1 to 2 prior lines of therapy for BRAF mutant metastatic colorectal cancer. And they were randomized to a combination of triplet therapy with benimetinib, encorafenib, and cetuximab versus encorafenib and cetuximab versus investigator's choice, FOLFIRI-cetuximab or irinotecan cetuximab. The primary endpoint of this study was overall survival and overall response rates for triplet versus the control and doublet versus the control. What we saw in the BEACON study in terms of overall response rates with the triplet regimen and with the doublet regimen, overall survival was fairly similar at 9.3 months for each doublet and triplet regimen. However, the control arms were only 5.9 months. Response rates were a little bit higher in the triplet regimen, but this did not translate into an overall survival benefit. And therefore, the FDA approved the combination of the BRAF inhibitor encorafenib plus an EGFR inhibitor. We also have some recent data on HER2-targeted regimens for metastatic colorectal cancer. The Heracles study looked at trastuzumab plus lapatinib for HER2-positive metastatic colorectal cancer, and they found an overall response rate of 30%. The MyPathway study looked at trastuzumab plus pertuzumab for HER2-positive colorectal cancer, and they saw a response rate of 31%. Now, the Mountaineer study is a little bit more recent study using tucatinib, which is a novel HER2-directed tyrosine kinase, and they combined that with trastuzumab. Now, they saw an overall response rate of 55%, but these patients only had 2 prior regimens of treatment, so a little less pretreated than in the Heracles or MyPathway study. Nevertheless, overall response rate of 55% is quite impressive. And then trastuzumab deruxtecan was explored in the Destiny CRC01 study. And those patients, again, had 2 or more prior regimens of treatment, and they saw an overall response rate of 45%, which is quite good. And they saw responses even in patients that had been treated with prior HER2 therapy. The Mountaineer study, which has just recently completed accrual looking at trastuzumab plus tucatinib, has reported, again, a 55% response rate. And we look forward to seeing more results with more patients on this study. But the preliminary median progression-free survival was 6.2 months and overall survival of 17.3 months, which is pretty fantastic for patients with 2 or more lines of therapy. Moving on to the NTRK fusions, again, we mentioned entrectinib and larotrectinib as the TRK inhibitors targeting these specific fusions. These drugs are approved irrespective of a patient's tumor type based on clinical trials that enrolled multiple solid tumors. The trial that established entrectinib included 54 patients with NTRK fusions, 4 of these having metastatic colorectal cancer. And the overall response rate was 57% overall and 25% in colorectal cancer, with a median duration of response of 10.4 months. Main side effects of this drug includes weight gain and anemia. There are other specific side effects such as heart failure, central nervous system effects, fractures, liver toxicity, QT prolongation, and vision disorders that we need to look out for. Larotrectinib also is a specific oral TRK inhibitor, and the trial that established this drug included 159 patients, 8 of them which had NTRK fusion positive colorectal cancer. The primary overall response rate was 79% and 50% in patients with colon cancer. And a median follow-up of over a year, the duration of response was 35.2 months. Now, the major treatment adverse effects in this patient population included anemia, decreased neutrophils, and an increase in liver enzymes. Special warnings for this drug include central nervous system effects, hepatotoxicity, fractures, and embryonal fetal toxicity.
Thank you. Sarah receives FOLFIRI plus bevacizumab because she was not a candidate for a molecularly targeted therapy given the absence of BRAF mutation, an NTRK gene fusion, or HER2 amplification or overexpression. She responds to treatment and tolerates it well, but develops refractory disease following 10 months of treatment. She subsequently receives FOLFOX. Although she experiences a partial response, disease progression is identified after 6 months. So, Dr. Eng, if we could look at third line and beyond.
Thank you so much, Stephanie. So, as mentioned earlier, Sarah has been exposed already to immune checkpoint inhibition, followed by FOLFIRI plus bevacizumab, followed by FOLFOX, and now we're looking at other lines of therapy. And so what we have available to us are 2 different agents, one being regorafenib. As many of you may be familiar with this drug already, but we're just going to highlight some of the points about it. So basically, it's an oral agent that's involved in angiogenesis, oncogenesis, and the tumor microenvironment. The FDA indication was based upon the phase 3 CORRECT trial, noting an improvement in overall survival after a 2-to-1 randomization versus placebo of 6.2 months versus 5.0 months and a hazard ratio of 0.77. In regards to potential toxicities, adverse events may occur earlier and diminish over time. The main side effects that have been reported are hand-foot skin reaction, diarrhea, and hypertension. And because of the development of toxicities early on at the full dose of 160, it's now been recommended to maybe dose escalate based upon the results of the phase 2 redose. So you start at 80 milligrams per day and increase by 40 milligrams to full dose if tolerated to 160 milligrams per day. And it's also very, very important to keep in mind to follow patients for potential hand-foot skin reaction, which is basically causes callus and blistering of your hands and feet, and it could be rather uncomfortable. So once again, it's extremely important to follow these patients closely. And please note, regorafenib is approved following the treatment for fluoropyrimidine, oxaliplatin, irinotecan, anti-VEGF, and anti-EGFR therapy if appropriate. Now, the other option, as I mentioned to you, is trifluoridine and tipiracil. So this is basically based upon the RECOURSE phase 3 trial, also similar study design to the CORRECT trial, and a 2-to-1 randomization versus placebo. And the median overall survival was determined to be 7.1 months versus 5.3 months for a hazard ratio of 0.68. And this was demonstrating improvement in overall survival, which is the primary endpoint, and that's why it's approved. It has different toxicities than regorafenib. It basically causes myelosuppression. So about 38% of patients had grade 3 neutropenia, and a little less than 20% had anemia. So these patients should be monitored closely in regards to their blood counts, and you may need to consider a dose reduction if needed. But once again, it's a similar indication to that of regorafenib, just different toxicity. So there are some recent data. So we do want to mention this. So there is some data looking at trifluoridine and tipiracil plus or minus bevacizumab. This is based upon a open label randomized phase 2 study. And that's why this was the recommendation to Sarah. It was a study of less than 100 patients. The median follow-up was 10 months, but they noticed improved progression-free survival for the combination with bevacizumab of 4.6 months versus 2.6 months, with a hazard ratio of 0.45. Once again, myelosuppression could be an issue for patients, so they should be followed closely. There's an ongoing phase 3 study looking at this combination in a randomized setting. So how do we individualize therapy in later lines of treatment for refractory colorectal cancer? So both regorafenib and trifluoridine and tipiracil are recommended following other standard therapies. They were based upon approval, based upon their overall survival. And also there was some improvement for the combination with bevacizumab for trifluoridine and tipiracil based upon progression-free survival. Here in this setting, no biomarkers have been identified which can predict which patients will respond to therapy with either regorafenib or trifluoridine and tipiracil. And once again, very different toxicities, and you need to take those into account when evaluating these patients and making that treatment decision. So the takeaway point here is choose later line of treatment based upon patient factors and adverse event profiles. Now, there has been some recent data looking at the role of this combination in elderly patient population. This is the TASCO-1 study, which was for treatment-naive patients. Primary endpoint here was progression-free survival, and 153 patients were enrolled. And it looked at trifluoridine tipiracil plus Bev versus capecitabine plus Bev. The median patient age was 75 years old. Once again, these were for frail patients that were not ideal candidates for intensive chemotherapy. The median duration of treatment was 7.8 months, and the PFS was 9.2 months for trifluoridine tipiracil plus Bev versus 7.8 months for CAPE plus bevacizumab. Median overall survival for trifluoridine tipiracil was 22.3 months versus 17.67 months at the final overall survival analysis. Now, there was an additional study looking at the combination of trifluoridine and tipiracil plus bevacizumab in the second-line setting. This is the TRUSTY study. And it compared it to the control arm of FOLFIRI plus bevacizumab, so a standard chemotherapy regimen in the second-line setting. 397 patients were enrolled in this trial, and the primary endpoint was overall survival. This was very surprising regarding the data. The median overall survival for trifluridine tipiracil was 14.8 months versus 18.1 months for the control arm with a hazard ratio of 1.38. The median PFS was also inferior at 4.5 months versus 6.0 months. So this study was terminated due to futility. So how do we improve adherence to oral line therapy in later lines of treatment? Once again, you really need to identify patients at risk for non-adherence and develop a strategy in how to follow these patients and make sure that they communicate well with you. Once again, toxicity management is key to ensuring timely delivery of the planned treatment. Must spend the time educating the patients, their caregivers, and all support staff when the patient reaches out to discuss potential toxicities. And then it's really important to reassure patients that regorafenib, once again, based upon the redose dosing, so dose escalation weekly, that the toxicities may decrease over time. And once again, you do not have to go to full dose of 160 if the patient doesn't tolerate it well. You can stay at 120. Once again, provide tools and strategies to help patients. In regards to oral treatment, we utilize calendar reminders quite frequently at our institution. And also, they can also make use of digital tools that are available on patient portals. So the takeaway point, once again, educate patients and their caregivers about the importance of adherence to oral treatment and optimizing their overall outcome. So what are the boot camp takeaway points? So once again, perform MSI or deficient mismatch repair testing on all patients diagnosed with colorectal cancer. Test all patients for RAS, BRAF, and HER2 amplification or overexpression. Genetic counseling is recommended for all patients with suspected Lynch syndrome. And also, if you have a young patient, you also may want to take that into account at all times because they may not know their full family history, and that could be extremely helpful. Consider tumor-sidedness, prior treatments, the expected overall response, and the patient's ECOG performance status and overall arching goals of therapy. Be aware of the recommended treatment settings and associated molecular markers for use of in immune checkpoint inhibition in metastatic colorectal cancer, and be alert to the type and potential for AEs associated with immunotherapy, and educate patients about those potential side effects. Choose later line treatments based upon the patient factors and potential adverse event profiles. So once again, regorafenib may have different toxicities, including hand-foot skin reaction, increased LFTs, versus trifluridine tipiracil, which puts the patient more at risk for myelosuppression. Once again, it's extremely important to educate patients and their caregivers about the importance of adherence when considering oral treatment.
Now, we do have some questions from our audience. The first question is, a patient died at age 44 from adenocarcinoma of the small intestine. They were diagnosed at age 41 in 1996, and there was no history of cancer in his family. Do you recommend any biomarker testing in his children who are now all in their 30s? I think this is an excellent question. Normally, we do try to test the tumor of what we call the index case, or the patient that had the cancer. But if this is not possible, then I think there are a couple of factors here that may influence me to recommend referral for genetic testing. One would be small intestine cancer. That's a little bit more rare than colorectal cancer. And so should be a diagnosis that piques your thoughts about an inherited cancer syndrome. And also the very young age at diagnosis of 41. So I think those two would justify at least referral to a genetic counselor who can go through the family pedigree a little bit more and determine whether testing should be done. I think in my mind, prevention is the best cure. So if it did happen to identify a syndrome and could lead to earlier screening in the family members, I think that would be important. I honestly think the likelihood of this patient having Lynch syndrome is fairly low, but as an oncologist, I like to err on the side of caution. So a second question is, please explain more about tumor-sidedness and prognosis. This is an excellent question. We don't know exactly why tumors on the left side of the colon and rectal tumors have a little bit better prognosis than right-sided and transverse colon tumors. We think it has something to do with embryological development is a little bit different between the last part of the colon and the rectum versus the early part of the colon and transverse colon. And we do know in multiple studies now, both prospective and retrospective, that patients with the left side of the colon tend to do better. And this was even before we had the EGFR inhibitors available. Now that they are available, this can also predict a response to the EGFR inhibitors, which gives patients another line of therapy to use and definitely helps prolong survival. Next question. Is there a benefit to using trifluridine to Pyracil in a patient with performance status greater than 2? That is another really good question. These patients were not included in the RECOURSE study, which initially looked at trifluridine to Pyracil versus placebo. So we don't know for sure. But we do know that survival, even compared to placebo, was not that dramatic, and progression-free survival was minimally increased. I think when a patient becomes performance status 3 or greater, that is a really good point to discuss best supportive care and hospice, because it is unlikely that any further treatment options is really likely to make a big difference. I think the rare exception would be previously untreated microsatellite instability high tumors, where they can go from a fairly poor performance status to a better performance status with treatment. But again, this is less than 5% of patients. And so not a lot of patients will be eligible for this treatment. I think at that point, once patients have reached an ECOG performance status of 3 or greater, time to refer to hospice. And the last question, what are the adverse events like in the investigational HER2 targeted therapies? Does one therapy have fewer adverse effects than another? So what we've seen in the dual HER2 directed therapy trials, particularly trastuzumab and pertuzumab, or trastuzumab and lapatinib, we have seen a lot of diarrhea, that being one of the major factors. With lapatinib, we can see some elevation in the liver function tests. And then, as always with HER2-directed therapies, there is a risk for cardiac toxicity, requiring the monitoring of cardiac function with echocardiograms. Of note, on the Mountaineer study with trastuzumab and tucatinib, patients appear to be experiencing a lot less diarrhea. That being said, I've had some patients on this trial, and we are seeing some increase in the liver function test, which is easily reversible with a slight reduction in the agent. So I think we will need to await more data on more specific adverse effects from this targeted therapy. But overall, it appears like the combination tucatinib and trastuzumab may have a better side effect profile.
Thank you for listening to the Practicing Clinicians Exchange podcast. To claim your credit, please visit pce.is/GIGU. And while you're there, don't forget to check out our website for more complimentary oncology CE/CME activities.